morning everyone. Let's deep dive into a topic that is very rare in cardiology, that is Takayasu's arteritis. Why Takayasu's arteritis? Let's think about it. We have many young patients, like in this case, a 19-year-old black Tunisian man was admitted to the emergency department for persistent median chest pain for 30 minutes. The pain occurred during rest, radiated to left arm and was accompanied with profuse sweating. The patient's ECG was as follows. His blood pressure was 140/80 and pulse rate was 150 beats per minute. Auscultation revealed normal breath sounds bilaterally with bradycardia without murmurs. As you can see, there's a ST elevation in 2, 3 and AVF and reciprocal depression in 1 AVL. So what would you do? There's complete heart block. Now, seeing this patient, the first thing that comes into our minds is take them to the cath lab. But this patient was endured and had intensive care, was started on aspirin, clopidogrel and unfractionated heparin, and coronary angiography revealed irregularities and aneurysmal coronary arteries without significant narrowing. So as you can see in the coronary angio in the at the right side, a saccular aneurysm in the RCA territory resulted in this kind of ECG changes and TIMI-1 flow. Pharmacological therapy like captopril and amlodipine was started and intravenous apixaban was initiated. This improved the patient's conditions and ST segment changes resolved within 2 hours. So when we talk about this case, we need to understand that not all cases of STEMI are atherosclerotic. They are also vasculitic, like the most common being Takayasu's arteritis. So we need to understand as a cardiologist and deep dive into the pharmacology, pathophysiology and the mechanisms of Takayasu's arteritis, and obviously the medical and the medical and the PTCA treatments like interventional treatments in Takayasu's arteritis. So let's start with the history. It is a pulseless disease or occlusive thromboaortopathy. In 1908, Takayasu was a Japanese ophthalmologist. She was a 21-year-old woman. He saw a 21-year-old woman with peculiar retinal AV anastomosis and absent radial pulses. In 1921, Shikare reported the first case in India, and in 1962-1971, middle aortic, it was named as middle aortic syndrome, and there were various associations with Mycobacterium tuberculosis in 101 cases. In 1993, Chapel Hill named Takayasu arteritis as a granulomatous inflammation of aorta and its major branches. Talking about epidemiology, the woman to men ratio is 8:1. The median age of onset is 25 years and it has been described worldwide, most commonly in Japan, India, China and Southeast Asia. But we need to understand there's a difference between the patients of Japan and the patients of India. That we'll talk on later. In Japanese patients, there's a higher incidence of the aortic arch involvement, whereas in the Indian patients, there is a higher incidence of abdominal involvement. The prevalence is 4 per million in Japan to 0.7 per million in UK. There are various publications like Sen et al. And Chetri et al. Which showed that female to male ratio is 1.5 to 1, with an Indian male who has more involvement of the abdominal aorta involvement and female involvement of aortic arches and its branches. So as I was talking about, that we need to understand how Indian patients are different from Japanese patients. Japanese patients have more of a thoracic aorta involvement with ascending aorta, descending aorta, whereas Indians and Koreans have more abdominal aortic involvement. Absent pulses and hypertension is the most common manifestation in Japan and India. Respectively. Hypertension is the most common complication in India, while AR, that is aortic regurgitation, in Japan. The Japanese tend to have a severe disease for a prolonged time, whereas in India, they have a shorter period of the disease with an acute inflammatory reaction. The sex ratio discrepancy, that is, as I told you, in Japan it is 8:1, that is a female to male ratio, whereas in ours the males have a Takayasu arteritis is also included in the males, that is 1.5:1. So talking about the pathophysiology of Takayasu's arteritis is that we need to understand that the etiology is still not decided. That is, there's arterial wall invasion by the cells via vasa vasorum. The second step is fragmentation of the internal elastic lamina, and the growth factors that infiltrate, causing the internal elastic lamina and the intima edema. So thereafter there's inflammation of inflammatory infiltration of the arterial wall by lymphocytes and monocytes, and again that will lead to tunica media degeneration and death of the vascular smooth cells and elastic disruption, dilatation of the arterial wall. Understanding the pathophysiology is important because we need to target the specific growth factors and specific chemotactic factors in these in this condition, so that we could fight against the disease, like IL-1, IL-2, IL-23, JAK inhibitors, anti-proliferative factors, anti-TNF alpha. These are the newer molecules, that is the biologicals that act against that can be used against Takayasu arteritis. So coming to etiology, exact etiology we don't know, it is still unknown, but proposed factors like spirochetes, Mycobacterium tuberculosis, streptococcal organisms, circulating autoantibodies, these have been proposed for the role in Takayasu's arteritis. Also genetics may play a role in it, and it has been seen that raised ESR and arthralgia and high titers are seen if anti-aorta antibodies are seen. Some patients have raised ASO titer. Female predilection is due to the hormonal changes, and it has been seen that estradiol and progesterone, but not testosterone, has enhanced leukocyte and leukocyte adhesion to endothelial cells, and that explains the female predilection of Takayasu's arteritis. So this is one of the theory by our sir, that is Kothari sir, that is an etiopathogenesis of Takayasu's arteritis and BCG vaccination. It is a very good theory that when it has been seen that patients of Takayasu's arteritis have increased tendency for Mycobacterium tuberculosis, and that is why this theory should be taken into this hypothesis should be taken into consideration. So talking about the natural history, so there are classically three phases of this disease, that is systemic inflammation and the pre-stenotic disease, stenotic aneurysmal arterial injury, and burnt out fibrotic disease. Whenever we talk about the clinical features of this disease, bruit, that is the vascular symptoms, are seen at presentation in 50% of patients. That is classically bruit, claudication, hypertension, carotidemia, and aortic regurgitation. Other features like CNS manifestations like lightheadedness, visual abnormality, stroke, musculoskeletal manifestations like chest pain, joint pain, myalgia, constitutional features, which amount to a very good number, that is 33% of the patients at presentation, and cardiac manifestation. We'll get into cardiac manifestations into a little detail later. So as I told you that there are multiple diagnostic features, diagnostic criteria of Takayasu's arteritis. First was the ACR-Euler criteria in 1990. Later on there was Ishikawa criteria for Takayasu's arteritis, and later on it was modified by Sharma et al. So let's talk about modified Ishikawa criteria, that is by Sharma et al. That therein there was major criteria and the minor criteria. Major criteria was left mid subclavian artery lesion, right mid subclavian artery lesion, and characteristic signs and symptoms of at least 1 month of duration. Whereas minor criteria were high ESR, carotid artery tenderness, hypertension, aortic regurgitation, pulmonary artery lesion, left mid common carotid lesion, brachiocephalic trunk lesion, descending thoracic artery lesion, abdominal aorta lesion and coronary artery involvement. So when we compare these two criteria, one thing that is important is the specificity has increased from 90 to 95%, but the sensitivity has tremendously decreased from 82 to 77%. So let's go on to the angiographic criteria for Takayasu's arteritis. That is one that involves the branches of aortic arch, 2A that involves ascending aorta, aortic arch and its branches, 2B that involves 2A plus DTA, 3 is descending thoracic aorta, ascending abdominal aorta, renal arteries, 4 is only abdominal aorta and the renal arteries, and 5, as you can see, is a pan-aortic disease. So we have to importantly consider that in Japanese people, 1 and 2A is more common, whereas in Indian people, 3 and 4 are more common. And also we need to understand that Japanese people tend to have more severe disease and a longer disease course than ours. So there was a cluster analysis that was seen wherein there were 1100 Takayasu patients. They were taken and divided into 3 clusters. So the first one was abdominal predominant, second was a aortic arch predominant, and the third one was a focal disease. So we need to understand the cluster 1 was more common in Southeast Asia and India, whereas aortic arch predominant was more common in Japanese people, and they presented to us with stroke, keratodynia, lightheadedness, and were less likely to achieve clinical remission. Whereas abdominal aortic predominant patients had renal hypertension and mesenteric ischemia, and they were more likely to achieve clinical remissions. So what is the frequency of blood vessel involvement? So as we can see that aortic arch involvement is the most predominant arterial involvement, that is in 65% patients, with aortic arch or root being 35%, abdominal aorta in 47%, and thoracic aorta in 17%. Another most common involvement is talking about a single artery, subclavian artery, that is the upper limb claudication that patients present to us with 93% of involvement. Renal artery being 38% and other arteries being least common. One important fact that we need to understand is pulmonary artery is the least involved, and it is involved in only 5% of patients. So next we need to understand the cardiovascular manifestations. Hypertension is most important and most common manifestation that is present in 30 to 80% of Indian patients, and it is most frequently it arises from the renal arterial involvement. Other causes like loss of elasticity of large vessels and coarctation of aorta. Up to 37% patients develop Takayasu's retinopathy. Aortic involvement is a significant complication of Takayasu's arteritis, but it is a least common complication in Indian patients as AR, and they need to be treated aggressively and should be sent for AVR. And also we need to understand that congestive cardiac failure is also one of the manifestations, and it could be due to hypertension, aortic regurgitation, and dilated cardiomyopathy. So talking about the coronary artery involvement in Takayasu's arteritis, J. Amano et al. Looked on 92 lesions wherein he saw that coronary ostia was most frequently involved, that is in 73%, and non-ostial proximal lesions were seen in 18.5%. Out of these 67% patients of left main coronary had more than 90% stenosis. Also AR was seen in 40% of patients, and we need to understand that important differential diagnosis of coronary artery disease as Takayasu's arteritis and should be suspected in young Asian women with angina pectoris. So diagnosis. So suspected Takayasu's arteritis should undergo MRI to investigate mural inflammation and luminal changes, and should be used as a first imaging test to make a diagnosis of Takayasu's arteritis. PET, CT and ultrasound should be used as alternative imaging modalities. In patients with Takayasu's arteritis, response to therapy should be assessed by MRA or CT angio every 6 to 12 months for first 2 years. In remission, that is after corticosteroids and withdrawal, annual MRA for relapse should be seen, and FDG PET with CT should be used for improved diagnostic accuracy. So, we need to understand the conceptual classification of imaging techniques. So, if we want to see for the arterial lumen, we need to undergo CT angio or an MR angio or a DSA. For the arterial wall, we need to undergo for a CT angio or a vessel wall MRI. And for functional characteristics, we should undergo USG, CT, contrast enhanced CT, and a T2 weighted MRI. So, deep diving into the differential diagnosis, there's a whole lot of a list of vasculitis which should be differentiated from Takayasu's arteritis. First important list that has to be differentiated is Takayasu versus giant cell arteritis. We need to understand that Takayasu patients are a younger group of population, more common in Asians, whereas giant cell arteritis are older patients, that is more than 50 years, and are Caucasians. The target vessel in Takayasu arteritis is aorta, whereas in giant cell arteritis, these patients present with temporal headache, and most common arteries to be involved is extracranial branches of the ECA, and the aorta is involved in 25%. These Takayasu patients, they present with systematic pre-occlusive phase and chronic occlusive phase, whereas giant cell arteritis patient present with jaw claudication and visual loss. So, cardiac involvement in Takayasu is 60%, whereas giant cell arteritis, they have less frequent CAD and myocarditis features. Another important differentiating feature of differential diagnosis should be atherosclerosis. Again, the age group is different in both of them. That is, Takayasu arteritis, these patients present in younger population, whereas atherosclerosis, they present in older. Important part is the vessel involvement is proximal part of the arteries, whereas atherosclerosis, they present at the bifurcation sites. Aortic aneurysms, they are both thoracic and abdominal in patients of TAC, whereas it is majorly abdominal in atherosclerosis. Coronary calcification is very rare, whereas it is more common in atherosclerosis. And upper limb involvement is very common in Takayasu. So, they present with upper limb claudication, whereas patients of atherosclerosis, they rarely present with upper limb claudication. Now, whenever we talk about the vessel wall calcification, rarely we undergo that, but let's talk about it. That is the histopathophysiology. There is a mural and circumferential with uniform and diffuse involvement, whereas in atherosclerosis, there is punctate, linear, and discrete plaque lesions. So, whenever we undergo PET CT, there is linear smooth signals in TAC patients, whereas there's generally localized punctate, linear, discrete plaque lesions in atherosclerosis. Talking about the Doppler USG, femoral artery, there's a halo sign or a Macroni sign, whereas localized thickening or intima of intima media complex is seen in atherosclerosis. Coming up to the medical management, the treatment options, we have to divide the treatment options for the flare portion of the Takayasu's arteritis and for the chronic occlusive phase. So, for the flare portion, we need to understand that there are glucocorticoids and there are steroid sparing agents like DMARDs and biologicals. DMARDs like the conventional DMARDs, that is methotrexate, leflunomide, azathioprine, MMF, and cyclophosphamide. Whereas biologicals like TNF alpha inhibitors, etanercept, infliximab, tocilizumab, abatacept, and rituximab. So, talking about the glucocorticoids, the dose in glucocorticoids is systemic glucocorticoids 1 milligram per kg per day for 2 to 4 weeks, whereas pulse dose steroid should be used for critical stenosis like coronary, carotid, or vertebral stenosis. So, for active TAC, for induction of remission, that is high dose glucocorticoid therapy should be started, and after disease disease control, it should be tapered to a dose of 15 to 20 milligram after 2 to 3 months of the therapy. After 1 year, the dose should be less than 10 milligram, and the relapse rate on tapering is 34 to 75%. Important is there should not be a rapid tapering. There should be a gradual tapering, which could lead to maintaining in remission. So another drug that has been used nearly in every patient nowadays is tocilizumab, that is a biological for Takayasu's arthritis. It has been seen in 36 patients that were randomized, double-blind and placebo-controlled. Tocilizumab 162 milligram weekly. They were started on tocilizumab, and the primary endpoint was not met, but tocilizumab was superior to placebo. Open labeled extended treatment was continued up to 96 weeks. Conclusions: steroid sparing effect with tocilizumab has been seen, and improved well-being on 36 item short form health survey was seen. So effects, so how to go about for the treatment of Takayasu? That is, on day 1, I diagnosed a patient of Takayasu's arthritis. I started him on glucocorticoids, plus I can start him on conventional steroids, conventional DMARDs, and or biologicals, and taper glucocorticoids to 15 to 20 milligrams within 2 to 3 months, and start him and thereafter less than 10 milligram of dose after 1 year. If the target is achieved, there should be the patient should be continued on glucocorticoids and DMARDs. If the target is not achieved, and if there are major or minor relapses, for minor relapses we can increase the dose of glucocorticoids to the last effective dose, or for the major relapse we should increase the glucocorticoid to 40 to 60 milligram per day, and we could add tocilizumab or TNF alpha inhibitors and taper glucocorticoids safely. If the target is achieved now, we can continue the same, or we could add newer drugs that are available. So coming up to our favorite topic, that is the endovascular. What do we cardiologists do about Takayasu's arthritis? As a general rule, we should understand that both endovascular interventions and surgery should not be performed during active disease. Indications for intervention: there are a lot more indications of intervention, like AR, wherein we need to go for aortic valve replacement, or ischemic heart disease, or supra-aortic disease with cerebral ischemia, mesenteric ischemia, severe limb threatening claudication, and refractory hypertension related to renal artery stenosis. We'll go into them one by one, and we'll talk about everything. Open surgery. Now, most common performed open surgery in Takayasu's arthritis is aortic valve replacement and aortic root replacement. Excellent outcomes have been seen even in active aortitis, although late aortic dilatation is common in this event. Thoracic and abdominal aortic aneurysms are usually treated with open surgery. So, aortic stents and stent grafts for some should be used. Distal lesions causing limiting lower limb claudication should undergo aortobiliac femoral grafting. So, when and where should we consider endovascular intervention, and where should we go for open surgery? Let's talk about the diseases individually. When the patient presents to us with supraaortic disease and cerebral ischemia, it has been seen that aortocarotid bypass has higher risk of complications and superior long-term patency, whereas endovascular treatment should be used for short focal lesions and high-risk patients. There was a study wherein there was seen that superior patency rates have been seen with surgical bypass, that is with 12.5% restenosis, compared to endovascular intervention with 50% restenosis. Despite use of endovascular interventions was seen in short stenotic lesions and bypass for longer occlusive lesions. Now let's talk about subclavian or axillary arteries. So typically stenotic lesions in this area are long, irregular and fibrotic. So intervention should be avoided and should only be reserved for patients in limb-threatening ischemia. So open surgery, there's a problem of difficult anastomosis and high risk of stenosis. Angioplasty should be reserved for short proximal lesions, and upper limb exercise to aid the development of collateral circulation should be advised. So let's come to diseases of aorta. If the patient presents with ascending aortitis, it leads to aortic root dilatation and AR, and AVR with replacement of the ascending aorta with a graft is a necessity. Whereas in patients with aortic aneurysms, that is with less than 2 centimeter and no progressive enlargement, there's a need of no intervention. Whereas if more than that and recurrent symptoms and progressive enlargement, both open repair and prosthetic graft and endovascular with endovascular approach should be used in such patients. Let's talk about aortic coarctation. So severe lower limb these patients present with severe lower limb claudication or refractory hypertension and open aortobiliac graft, they resolve claudication but only improve BP in 40 to 50% of patients. Endovascular in selected patients should be an approach with aortic coarctation wherein there are shorter segments of coarctation and there's no complicated disease. In patients in aortic dissection, first of all, it is a rare complication of Takayasu's arteritis that is present in less than 1%, and they present with type B aortic dissection, and usually conservative treatment should be approached. Now talking about coronary arteries. Vasculitic lesions and premature atherosclerosis are the major reasons for coronary arterial involvement, and these involvement, as we talked about earlier, are short and ostial, and almost critical stenosis is seen involving the left main stem followed by LAD and then RCA. CABG is preferred in symptomatic disease despite OMT. That has to be importantly noted that CABG is superior in such patients with Takayasu's arteritis as compared to PCI, because there have been various studies wherein they have been seeing that restenosis is higher with PCI as compared to CABG. So talking about that, Huang et al. Did a retrospective study of 90 Takayasu's patient, wherein 23 underwent CABG, 28 PCI and 39 were kept on conservative treatment, and they had seen that there was no significant difference in the cardiovascular death between medical treatment and revascularization. However, the proportion of restenosis was much higher in patients of PCI, that is 39%, as compared to CABG with only 8%. And heart failure is an important predictor of mortality in these patients. So now let's come up to renal artery. These patients have short and ostial lesions, and open aortorenal bypass is effective. Han et al. Showed that he did a study wherein 79% had non-atherosclerotic renal artery disease, and out of which 59% had Takayasu's arteritis. It has been seen that open revascularization had superior patency rates at 1 year and 5 years, and that is 91 and 80% as compared to endovascular intervention. So when the lesions are proximal and short, there is a better chances of patency with primary angioplasty as compared to stenting, and there's an Indian study by Tyagi et al. Wherein PCI was performed on primary PCI was performed on 54 patients with hypertension and renal artery stenosis, wherein 93% improvement in blood pressure was seen, but restenosis was seen in 13% and all successfully dilated. Talking about other studies, like Sharma and Gupta treated 264 renal arteries in 193 patients with renovascular hypertension secondary to Takayasu's arteritis, wherein they saw that there was clinical benefit in 91% of patients. There was improvement in hypertension, decreased need of antihypertensive medication, and 5-year patency rate of 67%. Whereas restenosis was seen in 17% and all were successfully retreated. Sharma group they concluded that renal angioplasty is more suitable than primary stenting in this young cohort because these arteries are fibrotic. There are higher rates of restenosis. There's technical difficulties due to tortuosity of the arteries. There's frequent vessel spasm during manipulation. Coexisting perirenal aortic stenosis also exists with renal artery lesions. There's long length of stenosis and insufficient landing zones, and tough stenosis can lead to incompetent stent expansion and increased risk of in-stent restenosis. So, talking about renal artery lesions, it is important to understand if the lesions are small, short and proximal, renal angioplasty is more suitable than open interventions. But if the lesions are long, irregular, fibrotic, open interventions are seen to have better patency rates in these patients. Meta-analysis of 7 studies have been seen that restenosis rates were significantly higher in renal arteries treated with a stent than those in primary angioplasty. So, important to understand is these studies have showed that balloon angioplasty is better than stenting these patients. So, talking about SMA or celiac trunk, symptomatic involvement is relatively rare, and if it is there, angioplasty plus or minus stenting should be done. Sharma and Gupta report that symptomatic lesions are often long and irregular and respond poorly to intervention. So, short and proximal lesions should again undergo PCA. Talking about a review by Jung et al., it is important and summarizing that surgical treatment is important in Takayasu's arteritis. The incidence of restenosis was lower in patients undergoing open surgical intervention than endovascular treatment, whereas the risk of stroke was higher in patients with open surgeries, and mortality and complications other than stroke were similar. However, various factors including the location of the lesion and the proximity of the lesion and the length of the lesion should be considered before surgical treatment, and it should be considered that whether balloon angioplasty or stenting or surgical intervention should be done for those patients. So, another study that they have the same study in the subgroup analysis, it was seen that more restenosis in coronary arteries, supra-aortic branches and renal arteries were seen in endovascular treatment, whereas stroke occurred less with endovascular treatment and mortality and complications did not differ that we talked about. So, let us talk about prognosis of patients with Takayasu's arteritis, that is 15-year survival rates in old Japanese studies. They had shown that with and without major complications, it was 66 and 96% respectively. With and without progressive course was 67 and 92%. And with ages, that is the diagnosis in patients of more than 35 and less than 35 is 58 and 92. So, more so ever, Takayasu arteritis has a better prognosis after the innovation with the biologics and glucocorticoids that has been used for remission of these patients. So, common causes of death in these patients are again myocardial infarction, CHF, that is cardiac causes, stroke, renal failure and aneurysm rupture. Now, we need to understand that prognosis has improved over decades, and another study that has reported mortality of Takayasu's as low as 2.8%. So, as we've talked about it, surgical strategy for thoracic aortic aneurysms in endovascular surgery era, there was a study by Oishi et al. Wherein they saw that the midterm outcomes of surgery for inflammatory thoracic aortic aneurysms were acceptable, although replacement remains the standard procedure for inflammatory TAs. TEVAR is a less invasive and an acceptable approach where inflammation is managed properly. Talking about pregnancy, pregnancy per se does not exacerbate the disease. Maternal complications like superimposed preeclampsia, congestive cardiac failure, or progressive renal impairment could be one of the complications in these patients, and abdominal aortic involvement is associated with poor perinatal outcome. An Indian series of 64 patients showed women with Takayasu's arteritis suffer from extremely high risk of poor maternal and fetal outcomes. So summarizing my talk, we as cardiologists, we need to understand why Takayasu's arteritis is important to us. It should be considered as a differential in patients in younger patients with coming to us with CAD, with saccular aneurysms on angioplasty, and they should be aggressively treated to reduce the mortality and have a better prognosis. Conventional treatments, conventional DMARD should be used as a first approach, and later on biologics should be added in these patients. Intervention should be reserved only for critical and severe diseases, and it should be and it has been seen that open interventions are better than endovascular interventions. Thank you.